Bismillah ar-Rahman ar-Rahim. Fractures of the distal radius, different options of treatment. Fractures of the distal radius are those fractures which affect the distal 1 inch of the radius. They are the most common upper extremity fracture. They have two peaks, childhood and in the elderly. In the elderly, they are more common in women. Risk factors are osteoporosis and postural instability. Falls on level ground cause most fractures, but other causes are traffic accidents and fall from a height. The distal radius has three articular facets: the scaphoid fossa, leonate fossa, and the sigmoid notch. The palmar surface is flat with a gentle anterior curve. The dorsal aspect is convex and has in its middle Lister tubercle. The strong volar radiocarpal ligaments attach to the volar lip of the radius. The triangular fibrocartilage complex arises from the base of the ulnar styloid to the edge of the sigmoid notch. The articular end of the radius slopes in an ulnar and palmar direction. This is the scaphoid fossa, leonate fossa, sigmoid notch, Lister tubercle, and the inclination is ulnar and palmar of the articular surface. These are the dorsal relations of the wrist, the 6 extensor compartments. This is a cut section through the wrist showing the extensor tendons dorsally and the flexor tendons and the median nerve under the flexor retinaculum. The volar radiocarpal ligaments are very strong. This is the radial collateral ligament. This is the radioscaphocapitate. The third one, radioscapholeonate, and the short radioscaphoid. On the ulnar side, the ulnoleonate, ulnotriquetral, and the ulnar collateral ligament. Fractures of the distal radius with dorsal displacement, increased dorsal tilt, and shortening are called Colles fracture. Those with volar displacement, increased volar tilt, and shortening are called Smith fractures. Those with intra-articular involvements with either dorsal or volar displacements of the articular fragments are called Barton fractures. Chauffeur fracture is a radial styloid fracture. This is Colles type, Smith type, Barton types, and Smith fracture. Classification. There is no one classification system that is comprehensive in describing all important variables of distal radial fracture. Fragment classification 1967 identified the individual involvement of radiocarpal and radioulnar joints and the presence or absence of a fracture of the ulnar styloid or distal end of ulna. It is descriptive, easily remembered, but it doesn't account for displacement. 1 and 2 are extra-articular, 3 and 4 are intra-articular, involving the radiocarpal joint. 5 and 6 are intra-articular, involving the inferior radioulnar joint. 7 and 8 are intra-articular, involving both the radiocarpal and the inferior radioulnar joints. Milon, 1984, put a classification for intra-articular fractures according to the displacement of 4 key fragments, which are the shaft, radial styloid, the dorsal medial fragment, and the palmar medial fragment. Its importance is the identification of the medial die punch fragment. This is Malone classification. Fragment number 1 is the shaft, number 2 is the radial styloid, number 3 is the dorsal palmar, and number 4 is the volar palmar. In type 1, it is undisplaced. In type 2, the die punch fragments act as one unit, either displaced dorsally or palmarly. In type 3, it is like type 2, but with a spike fragment. This is a special type, and its importance is the compression of the median nerve. In type 4, the dorsal and palmar medial die punch fragments are displaced in opposite direction. AO classification, 1987, classified distal radial fractures into 3 basic types, A, B, C, with 3 subtypes in each. Type A is extra-articular, type B is partially intra-articular, but the continuity of the epiphysis and the metaphysis is intact. Type C is complex articular fractures that affects the joint surface and metaphyseal area. AO classification in type A, it is either A1 with fractured distal ulna, A2 is Colles type, extra-articular, A3 is Smith type, extra-articular. In AO class, in type B, it is either type B1, fracture styloid fracture, B2, dorsal Barton, B3, volar Barton. In type C, it is either C1 with simple articular, simple metaphyseal. In C2, simple articular, complex metaphyseal. In C3, complex articular, complex metaphyseal. The universal classification, CONI 1990, type 1 is non-articular, undisplaced. Type 2 is non-articular, displaced. Type 3 is intra-articular, undisplaced. Type 4 is intra-articular, displaced, which may be reducible, stable, reducible, unstable, or irreducible. This is type 1, extra-articular, undisplaced, displaced, intra-articular, undisplaced. Type 4, intra-articular, displaced, which may be reducible and stable, reducible, unstable, or irreducible. Fernand's classification are put according to the mechanism of injury. It is either type 1, bending, which causes extra-articular fracture, either Colles or Smith. Type 2, shearing forces, which cause volar Barton or dorsal Barton. Compression, type 3, causes intra-articular fractures. Type 4 is fracture dislocation or avulsion fracture. And type 5 with complex mechanism of injury. The 3 model column or the 3 model concept are classified or classifying the distal end of radius and ulna into 3 columns. The radial column, including the radial styloid, the middle column, including the die punch fragment, which may be medial palmar or medial dorsal, and the ulnar column, including the head of the ulna and ulnar styloid. Radiological evaluation. In AP view, plain X-ray, the normal radial inclination is 22 to 23 degrees. The normal radial length is 11 to 12 millimeter. In the lateral view, the normal palmar tilt is 11 to 12 degrees. Tomography and CT scan are important uh, to, to give further information about the articular surface, the displacement of the fragments, and the affection of the inferior radioulnar joints. This is how to measure the radial inclination, the radial height, and the palmar tilt. Unstable distal radial fractures. Dorsal angulation of more than 25 degrees, or radial shortening more than 10 millimeter, or marked dorsal or volar comminution, intra-articular involvement, loss of reduction after cast immobilization, high energy fractures like road traffic accidents or falls from a height. Treatment options. Stable fractures, usually extra-articular, with no marked displacement or comminution or articular involvement, can be treated with closed reduction under GA and cast immobilization for 5 to 6 weeks. Follow-up X-rays at 1 and 2 weeks to be certain that reduction is maintained. This is example of extra-articular fracture with minimal dorsal angulation. It can be treated quite nicely with reduction under GA and cast immobilization. And this is X-ray after 8 weeks. For unstable fractures, cast immobilization only is not adequate and resulted in more than 30% incidence of complications, like malunion that affects motion and grip strength, persistent shortening with instability of the inferior ulnar joint that causes pain and ulnocarpal impingement, articular incongruity of 2 millimeters or more that causes painful arthritis. The fundamental principles of treatment of unstable fractures is the restoration of anatomy, the radial tilt, palmar tilt, length, and joint congruity, with the aim of producing full and painless motion of the wrist. This example of percutaneous spinning in minimally displaced fracture, minimal comminution, we can use reduction under GA and percutaneous spinning. Percutaneous cannulated screws for the same indication and especially in displaced radial styloid fracture. Closed reduction with a towel clip or reduction clamp, and then percutaneous cannulated screws. Open reduction and internal fixation can be done either through a volar approach for displaced volar marginal fractures, AO type B3. Those fractures are uncommon and tend to be associated with high velocity trauma to prevent radiocarpal instability and volar migration of the carpus. It can be fixed with a small T-buttress plate, 3.5 or 2.5, 2.7 millimeter. In comminuted cases can be combined with external fixator, K-wires, and bone graft. This is subtypes of type B3. Type B3-1 has a small fragment not involving the sigmoid notch. In type 2, with a large fragment involving the sigmoid notch. Type 3 is comminuted. Volar approach can be done through the distal part of an Henry anterior approach of the forearm, through the sheath of the flexor carpi radialis, and then between the flexor carpi radialis and radial artery, cut the pronator quadriceps and reflected ulnarly will expose the distal radius, or through the extended anterior or volar approach, which is used when decompression of the medial nerve is indicated in the same session, or to expose the medial die punch fragment for proper fixation. This is some example of open reduction and internal fixation for a volar Barton fracture. This type 1, immediately postoperative and after union. This a case of type 2, immediate postoperative and after union. This is a comminuted type B3, 3. We put a buttress plate and external fixator. A great breakthrough in the treatment of distal radial fractures is the invention of the volar locked plate, which has a good purchase or good fixation of the distal fragment. It is now improved also to polyaxial volar locked plate with polyaxial screws, or marginal volar locked plate for the more distal affection near the articular surface. Some examples of volar locked plates. Another case. In this slide, I want to show the CT scan can help us to identify the intra-articular fragments and to plan how to treat them. This is after fixation with volar locked plate. Volar locked plate is not an easy job, and we must do it very meticulously. If we don't take it seriously, it has a lot of complication which can happen in this procedure. Dorsal approach. It can be used as a limited approach adjuvant to ligamento taxis, as we come to it, to help in reduction of displaced articular fragments or for insertion of bone graft, or as a full approach preferred by some for insertion of dorsal buttress plate, plus or minus bone graft, plus or minus K wires, as a definitive treatment in complex articular fractures. The plate, however, must be low profile at a small plate, 2.7 millimeter or 3.5 millimeter, or a specialized distal radius placed once invented by the AO 10-15 years ago. The dorsal approach can be done between the first and second compartments, extensor compartments, especially when exposing the radial styloid fragment, or between the third and fourth extensor compartment when exposing the distal radius. This is example of intra-articular dorsal collis type distal radial fracture and how it was fixed by a dorsal low profile plate. This is the AO plate. It was invented about 10 or 15 years ago. I don't remember exactly. What about external fixator? Using the principle of ligamento-taxis, which means obtaining indirect reduction of comminuted intra-articular fractures by applying distraction on the capsulo-ligamentous structures of the wrist using the external fixator Vidal et al. 1970 improved markedly the results of treatment of distal radial fractures. Ligamento-taxis is effective in restoring the overall length and to some extent the inclination of the distal radius through a closed technique preserving the blood supply of the articular fragments. This is an example of comminuted articular distal radial fractures and fixed with ligamento-taxis only, and how nicely it was united, restoring the articular surface, palmar tilt, and most of the radial inclination. Another case of ligamento-taxis and after healing with acceptable results of the articular surface and about neutral palmar tilt. What are the disadvantages of ligamento-taxis? It doesn't always accomplish anatomical reduction of all articular fragments of a complex fracture. Excessive distraction and long period of immobilization, 6 to 10 weeks, needed to restore length in comminuted fractures may cause joint stiffness, disuse atrophy, and the increased incidence of pin tract infection. How to avoid this complication? By augmenting the external fixator, having achieved partial articular reduction, metaphyseal alignment, and radial length with the fixator in place, limited open reduction, dorsal, with pin fixation, reduction of the displaced fragment, and pin fixation, and putting bone graft, cancellous bone graft, iliac bone graft, improve the results and allow early removal of the fixator in 4 to 5 weeks. Bone graft substitutes may be used instead of autogenous bone graft like hydroxyapatite, calcium sulfate, pellets, or bioactive glass. This is example of augmented external fixator with percutaneous wires, and how nice was the restoration of the articular surface. Another case, the fixator was augmented with K wires and bone graft. A third case, the external fixator was augmented with K wire and bone graft. Fragment-specific fixation. This new concept is based on the 3-column theory. The idea is to fix each displaced fragment by a corresponding suitable implants through either dorsal approach, volar approach, or combined. These are some examples for the volar implants or devices, special hook plates, volar buttress pin, radial column plate. This plate allows K wires and screws. And these are some examples also for the dorsal applied special implants. You have to have the full set when doing this fragment-specific fixation. This X-ray is showing distal radial fractures fixed with a lateral plate and a dorsal plate. The dorsal distraction bridge plate is used subcutaneously between the second metacarpal and the dorsal radial surface. When the fracture is severely comminuted, it cannot be fixed with volar locked plates. So we put this distraction bridge plate to compress the fractures as much as we can in place. It is a type of internal fixator Instead of external fixator, this type of internal fixator. And we keep this for 3 months. And after complete union, we remove the plate. And strangely enough, the restoration of wrist movement after this period was not a problem at all. It can be combined with K-wires or bone graft. What about arthroscopically guided treatment? Wrist arthroscopy provides the ability to directly access the articular surface for step-offs and soft tissue injuries as scapholunate ligament tears, unitriquetral ligament tears, and triangular fibrocartilage tears, commonly associated with distal radial fractures. This is an example how to fix a radial styloid fragment with cannulated screw and guide this procedure through the arthroscope to see that the articular surface is reduced properly. What about complications? As we said before, malunion. We have to divide malunion into its different aspects, either joint incongruity or persistent deformity or excessive shortening. Median nerve neuropathy, reflex sympathetic dystrophy, compartment syndrome in crush injuries or following prolonged arthroscopy. Tendon ruptures. Tendon ruptures can happen in fractured distal radius in 4 different in 4 different occasions. Either minimal fracture, even a small fissure treated conservatively can result in rupture of the extensor pollicis longus. Also in volar locked plate, the tendon, when the screws are long, they can irritate the extensor tendons. And if we insert in volar locked plate screws distal to the pronator quadratus, it can cause irritation and rupture of the flexor pollicis longus. Also, when we used dorsal plates, it can irritate the extensor tendons and cause rupture. Non-union is rare, and the idea it can happen with I didn't see it before, but it can happen with ligamento taxis, so avoid excessive distraction. This is how to treat the persistent dorsal deformity and shortening. Here, it can be treated through a volar approach, osteotomy, and fixation with volar locked plate. It will leave a dorsal defect, like here, it is apparent here. This can be left to heal spontaneously or to put bone graft, iliac bone graft from the same approach around or under the brachioradials. We can also treat the same problem with Fernand's osteotomy. With osteotomy, open wedge, put wedge graft from the iliac crest, and then low profile dorsal plate. It was a very nice operation. Savocapangi, it is used when there is chronic arthritis of the inferior ulnar joint or ulnocarpal impingement. We arthrodese the inferior ulnar joint and excise 1 centimeter from the distal ulna to allow pronation and supination. Take-home message. Different methods are available for treatment of distal radial fractures. The choice of the method depends on different factors: the type of the fracture, stable or unstable, age of the patient, and the mechanism of injury, the presence of osteoporosis, implants available for you, and the facilities of the hospital, the experience and training of the treating surgeon. So don't be dogmatic and one-track minded in treatment or in treatment distal radial fractures with one method only, uh, because we can choose a simple method for a simple fracture for مثلا a lady in her 75s or something like this. Thank you very much.
Thank you so much, our great beloved Professor Ehab Negm, for this very, very interesting and illustrative talk. Thank you so much, sir.
Thank you, Professor Dr. Ehab.
شكرا.
Dr. Islam Abshafi, you are the moderator with our great professor. I see many questions to Professor Ehab Negm.
First question to our Professor Dr. Ehab, which is more important in choosing line of treatment, age of patient or classification or bone quality?
Age of the patient is very important. The presence of osteoporosis is a determinantal factor. The bone quality. And what are the third one?
Is it patient age or classification or bone quality?
In my opinion, the three are very important. I have to know if it is just a simple fracture in place without comminution. I can treat it conservatively. Reduction under GA, below elbow cast, and even after 1 week, if I found it is a little bit or displaced, I can repeat my reduction and go through the conservative treatment, especially if there's an old lady with a lot of comorbidities.
Yes.
If I have a fracture and severe osteoporosis, I cannot put simple things. I have to augment it with external fixator to prevent shortening.
Yes, sir. Second question, is it mandatory to bend radio-ulnar joint?
If it is not affected, it is not mandatory. There is a lot of opinions or designs for percutaneous pinning. Some goes after putting 2 pins through the radial styloid to put 1 pin transverse and take the inferior ulnar joint for more stability. Another, they stop when the inferior ulnar joint are not affected at all. They stop before the inferior ulnar joints. Another design, they go through the ulna to the radius after putting the radial styloid pins. They go through the ulna to the radius, transverse pins. So it is, it have different designs, but you have to put enough pins to stabilize the fracture and prevent redisplacement during healing.
Yes, sir. Another question, patient with distal radius Barton fracture type P3 refuses surgery. What is the result?
The result is volar instability of the carpus, volar migration of the carpus. The results are very bad. The absolute indication of surgery in distal radial fracture is volar Barton from about 60 years or 50 years.
Yes, sir. Another question, what does the polyaxial plates added to prognosis of treatment?
Honestly, I didn't use it till now. I use the fixed angle. I didn't, I have no experience with the polyaxial or the marginal. I didn't use until now.
Yes, sir. Another question, what is the maximum timing to utilize ligamento-taxis idea?
Yeah, to use ligamento-taxis is through the first week after injury. After that, maybe the fragments will start healing. So ligamento-taxis will not offer the dire distraction. So you have to do it early. If you want to do ligamento-taxis, you want to do it early, third day, fourth day, seventh day maximum.
Yes, sir. Another question, how to apply bridging plate according to soft tissue details, please?
We put the plate through incision over the second metacarpal, and then you slide the plate. We usually do use about 8 to 10 holes plate, narrow DCP. Then you slide it under the bone, and another incision at the distal forearm dorsally, and you put your screws, two or three screws distally and 3 screws proximally. If you want to try to reduce the fracture, or you will put K-wires, or you want to put bone grafts with this bridging plate, you can expose the distal radius through dorsal approach, as we explained before. Do your job, reduce as much as you can, put your K-wires, put some graft, and then slide the bridging plate and fix it, as we said, in the second metacarpal and proximal to the distal radius with 3 screws.
Yes, sir. Another question, in comminuted fracture and shortening, is grafting and the K-wire with cast is okay, or need external fixator to avoid shortening?
It is external fixator is needed in this case. As we said, with osteoporosis, you are afraid of severe shortening to happen. So you augment your K-wires with the fixator to prevent shortening.
Yes, sir.
احنا اسفين يا استاذنا دكتور ايهاب بالاسئله كتير
أسئلة
لسه.
كتير طبعا.
لو هتتعب سيادتك.
لا يا فندم، تحت امرك.
اتفضل يا استاذ، اتفضل.
Another question, which classification would be the most reliable to determine the most suitable treatment module?
In Colles fracture, this was a problem through the 50 or 60 years ago. Each type of classification put you or inform you about an important issue. Fragment inform you about the radiocarpal or inferior ulnar or both involved. It doesn't talk at all about displacement. Milon inform you about the displacement, and the first to define what is the medial displaced fragment, which he called the die punch. He imagined the lunate as a punch, and it strikes the articular surface of the radius medially to have this fragment, the medial die punch fragment. And further, it can be divided into 2 parts, dorsal and volar. So Milon was the first to, in his classification, to highlight this die punch fragment. AO classification is very good, as in any other fracture, and simple to memorize. It's either extra-articular type 1, partial articular type B, or complete articular type C. and the details also are not difficult. Fernandez is classifying according to the mechanism of injury. It was not mentioned in any classification before. Bending, shear, compression, avulsion, complex, and the CONI classification are also either extra-articular undisplaced or displaced, okay. Intra-articular undisplaced, okay. Intra-articular displaced, it was reducible and stable or unstable or reducible and irreducible. And this corresponds, مثلا, to AO type C 3, a 3-column theory, 3-column concept are the basic for the fragment specific fixation. I will fix the medial, the lateral column by lateral plate, and then go to the middle column and put dorsal plate. If the ulna has something, I will put مثلا K wire. So it is based on this 3-column theory. But you have to have the full set of implants, and you study these implants thoroughly before you use it, because they are about 8. Each one is for a corresponding fragment. So you have to use it in different types here.
Yes, sir.
It is not cheap.
Yes.
دكتور
another
اسلام عندي سؤال كده بس
اتفضل
لو
يا فندم، اتفضل.
steroid process ulna during with fractured distal end radius, do you prefer to fix it or not, and which method do you fix it?
يعني I fix it in some cases when I feel it is there is instability of the inferior ulnar joint. If I can fix it closely with 1 or 2 K wires, as I did in one of the cases here, it is okay. Or I open and put something like circulation.
Yes, sir.
Thank you.
Another question. What is the difference between below and above elbow cast in distal radial fractures?
يعني it is found after many years that there is no difference in the results, except in my opinion, if you feel instability of the inferior radioulnar joint, please put it above it. You will not lose anything. If you feel a problem or instability in the inferior radioulnar joint, put it above it. If it is so stable, so forgiving, you can, as our late Professor Ahmed Wael Farag, he put dorsal slab, not complete cast.
Yes, sir. Another question. Post-operative regimen of patient treated with percutaneous binning.
Post-operative regime?
Regimen of patient treated with percutaneous binning.
Okay, يعني after 6 weeks, you remove everything. You remove the pins, you remove the cast, and do another X-ray. Usually it is united, and you can start active mobilization. Don't put anything in the distal radius beyond 6 weeks because of stiffness.
Yes, sir. Another question. Volar or dorsal lip fractures, how would you fix, sir?
Volar or dorsal what?
Lip fractures.
Like dorsal Barton.
Yes.
Okay. For me, I'll go dorsally, fix it, and put a dorsal low profile plate, as in the case I just showed the print. Nothing will happen. I want to say that these all methods are weapons with you in treating dorsal radial fractures. You choose according to the personality of the fractures and the other factors we mentioned. I'll use this weapon in this case. don't be dogmatic. I will use volar locked plate in all cases, percutaneous pinning in all cases, external fixator. This is not right. You have 8 methods. You have 8 methods and different type of fractures. Each type may be in your hand. You will possible to use this method. You will give good results in your hand with training, with your own training. And the volar locked plate is not an easy job. Volar locked plate have to be done meticulously. If you put screws long, it will injure the extensor tendons. Screws distal, it will injure the flexor pollicis longus. If you don't fix the die punch, the radial styloid, each fragment is fixed properly, it will displace. And a lot of X-rays show this. You put a plate, but it is not fixing the radial styloid. Sometimes, because I show it in the pictures, I put K wires when I feel that the radial styloid is not fixed properly by the plate, I put K wires and keep the K wires and remove it after 4 weeks.
Sir,
it needs
last two.
training.
Yes. Yes, sir. Last 2 questions. Principle and significance of Kabanji technique in distal radial fractures.
As we said, if the problem, it is malformed, the inferior ulnar joint is neglected for many months, there is pain, chronic pain in the inferior ulnar joint, painful limitation of pronation and supination, you can use this method to arthrodese the head of the ulna to the distal radius to keep the shape, to keep the stability of the wrist, and then you put you invent a joint, a new joint, proximal to the original joint by removing 1 centimeter from the ulnar shaft to allow the movement. It is very nice operation when it is indicated properly.
Okay, sir. Last question. What is your opinion, sir, about using balloon blast in treatment of distal radius?
معلش
هو ده question من دكتور محمد عبد العال.
بالون بلاست اللي هو
بالون
بلاست.
انا ما اعرفوش يا حبيبي والله، لو اعرف اقول. انا لو اعرف اقول بس ما اعرفش.
لا, this is a method for to elevate the subchondral bone and then injected the bone cement or bone substitute in the defect.
ماشي، بدل الجرافت يعني بيحط السيمنت.
بالظبط، او يحط، لا هو يعمل سبيس كانه بيعمل elevation عن طريق البالون نفسها.
يعني في بالونه هتخش في الديستال راديوس؟
يحطها انجكتابل كده كانها ترفع.
ولون البالونه بيبقى ايه؟
زي الارتيكولار سيرفيس عشان تعمل elevation للارتيكولار سيرفيس.
هل في لون معين للبالونه؟
مش عارف.
بعد اذن سيادتك يا فندم، سؤال مني يا دكتور ايهاب بيه. انا كنت بناقش رساله ماستر في طب المنوفيه، كان على الديستال راديال فراكتشرز وذ ميتافيزيال كومبينيوشن، والريسيرشر كان عامل تكنيك لطيف جدا، هو بيعمل كلوزد ريدكشن اندر جي اي، وحضرتك بعد كده بيحط البيركتينيا سبيننج وثرو اي فيري سمول انسيجن، دورزال انسيجن، بيحط بون سبستيتيوتس عشان يمنع اي ميتافيزيال كولابس ليتر اون. What about this technique, sir?
جميل. يعني بيحط البين
البيركتينياس كله، وبعدين ثرو a very small incision dorsally.
بتاعه البينيك برضه نوعين، في البيركتينياس الاكسترا فوكال، وفي نوع بتاع الكابانجي انا ما جبتش سيرته اللي هو الانترا فوكال.
تمام صح.
المهم هنحط بينز، وبعدين هو ثرو ليميتد دورسال ابروتش بيحط بون جرافت.
بيحط بون سبستيتيوت بقى يا فندم على اساس ما يعملش
سبستيتيوت. انا جبت سيرتها حضرتك.
تمام سعد. تمام.
يا اما هيدروكسي ابتايت او كالسيوم سلفيت او بايو اكتيف جلاس. واي نوت. جميل.
تمام. تسلم يا فندم. في اي اسئله ثانيه لاستاذنا الكبير؟ احنا تعبنا استاذنا دكتور ايهاب يا دكتور اسلام.
لا ما في no questions سير. no other questions.
احنا طبعا بنشكر استاذنا الكبير بروفيسور ايهاب نجم. هي محاضره عظيمه لمحاضر اعظم يا فندم، فطبعا الاسئله كتير يعني.
لا تحت امركم.
احنا سعدنا بوجود سيادتك معانا النهارده يا استاذنا الكبير.
الله يخليك.
وشرف كبير لنا تواجد حضرتك معانا في الكورس يا دكتور ايهاب بيه.
انا متشكر.